them useful. We've got a period of time to go through this. I'm mindful it is recorded as well. So although I'm doing this at the moment and no one is watching live, I'm sure there's going to be people watching this back for the recording. So I've managed to whittle this down to 20 questions that people had put on my Instagram story. Loads of good questions that had come in, and actually the 20 that I've managed to pick hopefully give the most well-rounded approach. I hope you find it useful. I'm looking forward to it. I'm going to give it just a minute or two because I've only just shared the link. So I'm just going to give it a minute or two to see if anyone's going to be jumping in live. And also, like, if you are watching it live, you're more than welcome to kind of put any kind of questions in live as well. But I'm just going to give it 1 minute just because I've only just shared the link. So there's going to be some people that I think will want to watch it live. And I've had quite a few people message saying that they're going to be watching the recording back as well. So we'll just wait for a minute and then we'll go through it. But just looking at these top 20 questions that I've picked, I've got quite a big list: GTPS, dyno, acupuncture, hip scopes, dysplasia, FAI, management, treatment, surgical choices. I mean, to be honest, there is quite a big list of different questions. So I can see a couple of people starting to trickle in. First time I'm doing this YouTube live, so it'd be good to know if you can type a message. Feel free to, just so I know that that's even a thing over here. But people are starting to trickle in now. So I'm going to start because I want to make sure that we cover as much of these as possible. And I'm doing this in between a lunch break, doing a remote clinic. So hopefully we can get them all done. But we're going to kick it off. So the first one is GTPS recovery time. So greater trochanteric pain syndrome. Now this is what inherently gets blamed and people refer to it as bursitis. Now GTPS, greater trochanteric pain syndrome, it is stubborn, guys. It is a stubborn condition to treat. It's a tough condition to treat. On the surface, yeah, it might look like just a tendon related issue, because it's normally like the gluteal medius or minimus tendons which cause the problem. Sometimes you get a bursa, not often, but sometimes you can get a bursitis as well. But the recovery times are long. I mean, we're talking about something that will take like months and months and months for it to settle down. This isn't something that's going to just get better in like 2, 3, 4 weeks. It will take a long time for it to settle. And it's important to like discuss that with patients. You know, patients can get quite demoralized if they think that something's going to take a few weeks to resolve and it doesn't. And if it takes like months and months and months, then so be it. But you need to explain that to them. The natural history of progression of this condition can take a while for it to settle down. And sometimes you don't see like very quick changes like in their recovery. So you might be treating someone and doing all the right things, and they might be diligent and they might be compliant. And even then, sometimes it just might take a while for it to settle down. So when you're seeing that patient, or if you are that patient and you are in the early stages of having it, don't be despondent if you don't see immediate changes. Just make sure that you optimize everything. Make sure that you're doing everything correctly. Make sure that you don't treat it incorrectly. Make sure that you don't miss any other diagnoses, and just consider the fact that like this can be something that takes a little bit of time for it to resolve. There are so many factors and variables with GTPS: metabolic, hormonal, systemic, musculoskeletal, exercise. There's so many factors that we just have to consider that, and don't rush it, and just make sure patients are aware of that. And my bit of advice with this is don't chop and change too much. Don't flip between one treatment to the other treatment. Just make sure that you're optimizing everything and doing everything as effectively as you can do, and things will eventually start to improve. It just takes a little bit of time. So don't rush. I can see we've got 7 people on live at the moment. We're going to break the internet, you 7. Go on. Can someone just type something? I don't even know if that's an option. I'm sure I've seen people on these things typing. How much of a granddad do I sound, by the way, sitting here going, oh, I've seen someone be able to type on these things before, but no one has typed. So I don't know if you've even got access to that. Maybe that's in my best interest if you're not hammering me with absolute abuse while I do this. Right, question number 2. Oh, John, you can type. And I appreciate you not giving my first message as abuse, so I appreciate that. Number 2, ideal tests for the hip. Now, this one came in as a question trying to identify how you can diagnose FAI syndrome or hip impingement. Guys, the clinical tests that we have, especially for joints, are inherently flawed. So tests like the Feder's tests, which often is done, and you kind of think Feder's test and hip impingement or FAI syndrome, that is not a clinical test that you can use to diagnose anything. It's got a very low level of specificity, meaning that specifically it's hard to link it to a pathology. Now you can use it to rule out a hip pathology because it's got a high sensitivity. But if you think someone has FAI syndrome and you're doing a test like Feder's test and it is positive, all that is telling you is that it might be the hip joint, but pathologically what's driving those symptoms is really hard to determine. So you can't really utilize them. And that's why a lot of these clinical tests are limited. So you need to just consider that and not necessarily jump to thinking, what's the best test to do? A lot of it is through a way of trying to like refute or nullify your thoughts and your reasonings, and a way to try and think, well, it could be these things. These tests will help me just isolate if it is more towards this or more towards that, but it certainly isn't one that we can use to definitively diagnose, especially when it comes to the hip joint. Now, there are other tests, especially when we do things like look at gluteal tendinopathy, or proximal hamstring tendinopathy, tendinopathies in general, where you can be a bit more specific about palpating, about testing contractile pain provocation. That will start to push you towards particular structures and components. When it comes to the hip, it is difficult. So it's really challenging to say for things like Feder's test, is that the better test to diagnose a hip pathology with FAI? I'd say it is limited, but you still use it to try and kind of understand what's going on. This third one is, so it says, what is my favorite hand dynamometer? So I use something called a K-Push, which is from a company called Kinvent. I've got no shares in the company, but it's a great bit of kit that I think hand dynamometry has great value, but for the right individual, if you don't need to use it for everybody. But the point that I definitely want to highlight with handheld dynamometry is that it gives you data. Like, you can't tell if someone is weak by just doing manual resisted pressure tests, because the thing is, there is so much that can inhibit that. You can't justify, you can't say how weak someone is by just pushing against your resistance. Now, sure, you can understand if there is motor loss or like muscle activity loss, but you can't understand percentage wise, where is it deficient in strength and how can we identify that? And that's why the handheld dyno testing for me is really useful, particularly with things like cutting-based sports, adductor-related injuries, where you're having to look at balances and asymmetries and deficits, all of which are risk factors for injury. So I think those are important things to consider and not forget. But I know there's loads of different different tools and gadgets, etc., that a lot of people use. So that's just the one that I use. Acupuncture. What do I think? Acupuncture. So look, I've been a physio for 15 years. There was a long period of my career where I used acupuncture. So I would be a complete liar if I said I don't believe in it and never used it. I don't use it now, but also I'm not in the kind of patient group that I see. It's not the right kind of environment, the kind of patient. So I get that some people really benefit from it. I haven't done it for years. The only time I ever did use it was when it was like kind of into muscles. I never really knew or could understand confidently what even was going on. But, from a pain relief perspective, some patients benefited from it. And also, if I've got patients that are coming to see me now with complex hip issues and they're having treatment elsewhere for things like acupuncture and massage, and it's not going to necessarily make their problems worse, I support them and say, if you want to carry on with that, that's fine. But I don't personally use that for various reasons, really. But I get there's loads of things patients will do. You've got to remember that patients are in pain and they want pain relief, so they'll seek that. But our job isn't to slate other professionals. It is to try and just educate, advise and guide with those kind of things. But I did use it. I definitely don't use it now. Right, question number 5. I'm waiting for a hip replacement. What can I do now to get a faster recovery? Key headlines with this stuff. Keep active. Keep strong. Keep psychologically resilient. Prepare. Optimize your outcomes by having rehab ready. Know who's going to be doing your rehab and know what to expect from the surgery. As soon as you start optimizing all of these things, you start to get a better understanding in regards to what's coming, and it prepares yourself mentally. All of this recovery is a balance between psychologically being resilient and physically being resilient. If you can optimize those two things and almost prehabilitate yourself by doing that, you're going to be onto a winner. And actually, those things will help speed up recovery if there aren't any other factors to play contributing to things that might inhibit your recovery potentially. I've got a couple. Let me have a look, because Paul, Taylor, you've put some questions here. I'm just going to see if it's relative to this. You put fascinating stuff, so much to understand. Injured myself last year, 11 months now. Experienced popping sensations to the left hip joint, then had bruising and on and down the hip outside of my quad. Went to a specialist, had MRI. He said the muscle was clear. Okay, cool. So that's a little bit more like specific. These things like this, Taylor, I'd love to be able to get involved, but it's tricky to give like specific direct medical advice with things like this. And I would say it's not in your best interest for me to, because there are so many different components that could be contributing towards that. But look, if you've had an injury from 11 months ago and you're still having hip pain during exercise now, I'd probably hazard a guess to say, well, look, go and see someone to try and understand why, and understand really why you're still in pain, because you shouldn't be if it's still 11 months down the line. So just try and make sure you're asking those questions to the right people to understand what it is that's driving it. Question number 6, will I need surgery in the future if I had FAI surgery in both hips? Now, a hip arthroscopy for FAI is a hip preservation procedure. There is a spectrum of hip health, right? You have a healthy hip and you've got precursors or risk factors of arthritis like hip dysplasia, like FAI syndrome, that can lead to an arthritic hip. However, having a hip scope is a preservation procedure. That is essentially to take away potential pathological driver that contributes towards an arthritic hip producing. So things like a cam removal, things like labral repair, things like a pincer resection are done to try and mitigate the progression. However, the important thing here is in some cases that works fine. In other cases, you have to also appreciate the fact that any surgical procedure that someone has may well contribute towards some sort of arthritic presentation in the future. We can't disregard that possibility. But you would hope that having that surgical input should hopefully abate or mitigate the risk. So I definitely say don't kind of like presume that you're going to need to have further hip replacement in the future if you've had a hip scope to try and manage or resolve your FAI in both hips. Moving on from that, question 7, surgery for FAI syndrome after 16 weeks of PT. Is that too soon? I would probably say 16 weeks is probably pushing it. You really want to put off having surgery for as long as possible. There is always the unknown when it comes to hip surgery, especially with a hip scope. So you don't want to dive into having hip surgery if you don't need it. And also you need to understand that if you have FAI syndrome, for it to become symptomatic, it takes a long period of time for it to get to that point. You aren't going to necessarily resolve it conservatively that quickly. You have to give it time. You have to give it scope to progress within PT. And sometimes I'd say 16 weeks might just be on the cusp of it being a little bit too soon. But that's not to say that others who have done it sooner haven't done well. So don't kind of like make that decision to have surgery or not just based on me giving you a 2-minute bit of context or answer, but the context I think is really vital for you to understand if that surgical decision is yours or not correct. Understanding who the ideal surgical candidate is something we're still trying to understand. Right, here we go. So question number 8, resurfacing or total hip for a 37-year-old who wants to be active. I must have this conversation at least every other day. I am a huge advocate for both, but I'm an even bigger advocate for a total hip. There is so much that you can do with a total hip, and the longevity and the survivorship and the robustness of them now are fantastic. You can have an active lifestyle, you can do exercise, a high level, you can run, you can do triathlons, you can do pretty much most things bar contact sport. So the question is, would you be looking to have a resurfacing because you want to get back to a sport? Or are you doing that with the hope of getting back to high level exercise? Because I think the argument is you can still do that with a total hip, not necessarily needing to have a resurfacing. The resurfacing things are progressing. You're going to have ceramic on ceramic. We're hoping to see further longevity of resurfacing that we see at the moment, metal on metal still has some risk factors that are associated with it. So for that person, I'd say don't disregard the possibility of a total hip. Number 9, what muscles do I have to make stronger to stabilize the hip and for pubalgia? Now, we can probably tie this in with question 18, which is the best treatment for insertional adductor longus tendinopathy, because these things will come hand in hand in the sense that when you're dealing with someone who has pubalgia, which is kind of the umbrella term for things like inguinal related groin pain, pubic related groin pain, adductor related groin pain, the reason that we have these classifications is because it's inherently difficult to identify singular causes of where symptoms are coming from. The key trio of principles that I always adhere to for these patients are the 3 amigos. And anyone that's been on my course will know that we discussed this at length. And those are essentially the 3 amigos at AAA, right? The abdominals, the adductors, the abductors. These 3 amigos, right? These 3 AAAs have to be in harmony and addressed because they all work together, they all work in harmony, and they all need to have some degree of approach when treating people who have pubalgia, inguinal, adductor, whatever you want to refer to it. So I'd say for those 2 ones, remember the 3 amigos: abdominals, adductors, abductors. Right, now we've got number 10. I'm doing all right for time. I'm doing all right, you know. This is fairly, I'm obviously going to run out of time now I've said that. But can you treat cam impingement without surgery? Yes, you can, because a cam develops when you are 14, 15, 16, around a pre-adolescent, adolescent age. Usually presents in young adulthood, 20s, early 20s, late 20s. You would have had that cam there for best part of a decade, if not more, before it starts to cause symptoms. So you cannot say that there is only the option to have surgery when it's hard to identify why it's even become painful in the first instance. So you shouldn't jump to having surgery first. There is a lot that you can do with physio to rehabilitate the hip. Understanding that FAI syndrome is a movement-related clinical issue of the hip, meaning that movement is the thing that's driving it, and equally understanding that movements are the things that we can control with physio to try and mitigate progression, and that is absolutely vital. So can you treat cam impingement without surgery? Categorically, 100% yes. Number 11, is leg length discrepancy common with FAI or muscle imbalance? Leg length discrepancy, among other things, is something that always people get blamed about, or it gets given as a blame for people who have hip pain with flawed clinical reasoning. Flawed clinical reasoning in the sense that often people have subtle discrepancies and have no issues, and often people are blamed about discrepancies with poor assessment. When it comes to FAI syndrome, discrepancy is not a relative, so it's not a related thing that we look for. It isn't something that has any correlation to FAI syndrome at all. So we can put that one to bed. Muscular imbalance, again, may well possibly be evident in people who have hip pain from FAI syndrome and helps guide the rehab and the management when you're trying to physio them. However, there isn't evidence that demonstrates that muscular imbalances or weakness in these muscle groups is a direct reason why someone has FAI syndrome related hip pain. Those 2 things are not distinctly correlated or really causative. Maybe some with muscular strength deficits, but certainly not like distinct drivers to their hip pain. Number 12, is borderline hip dysplasia a thing? Ladies and gentlemen, if you check back in about an hour and a half, you'll see a new post I'm going to post up with E3 Rehab, where I've done a podcast with them, 1 hour, completely, totally on hip dysplasia. It's the first podcast that I've done that has been exclusively on hip dysplasia, and it will cover pretty much everything that you need to know. And I would highly recommend it because I really enjoyed doing it. Borderline dysplasia is a contentious thing. Yes, you can have borderline dysplasia, and yes, it often gets misdiagnosed and unfortunately often gets missed, and something that we have to be more aware of at identifying, picking it up, and signposting people effectively so they can get the correct treatment for it. Right, we've got 5 or 6 questions left. If you're enjoying this, definitely press the thumbs up so people know that it's not absolute rubbish when they come to see it and they think, oh, geez, no one actually watched that. So if you can do that, that'd be helpful. Right, we've got 5, 6 left. This one I think is really kind of hits home, right? So it says, it feels like all the evidence is contradictory and I'm always doing something wrong as a sports PT. How telling is that like people feel like that? And I used to feel like that, right? You know, if you kind of look at Twitter, look at maybe Instagram's better, but you look at Twitter, you go on like read papers and whatever you do, there's always something that contradicts something else, right? You always think that you're doing the right approach and someone's slating it, or there's evidence that's been published that disregards it. And, you know, even if it comes to the manual handling, manual therapy side of things, or the acupuncture, or whatever it might be, there's still more that we need to understand. Now, when it comes to hips in particular, there is a lot out there that probably, unfortunately, people are being advised on and treated on with narratives and approaches that might be a bit dated, that at the time had good intentions, but now we understand, you know, probably aren't the right things to do for certain things. And I think what we have to appreciate when it comes to healthcare practitioners is that it's fine to adapt, it's fine to progress, and it's fine to kind of change the way you work as the landscape of things develop and change as well. For those of you who are PTs and thinking that, oh, am I doing the right thing? Am I doing the wrong thing? Look, if you're evidence-based in your clinical reasoning, if you are using clinical reasoning, if you're keeping up to date with literature and you're following like proper guidance from that perspective, then the likelihood is you'll be doing the right approach. But you know, it'd be a bit boring also if we all just did the same thing. So there is going to be a bit of variability. There is going to be a bit of things that kind of like change from clinician to clinician. And we just need to kind of consider that we are doing things that are evidence-based. Number 14, can you do weighted hip thrust after a hip replacement after 2 years? 100% yes, you can. If you're 2 years post hip replacement, I'd be wanting you to be doing whatever you want to be doing. Maybe not professional rugby, maybe not professional football, but you could probably get back. And I mean soccer, by the way, right? People who are watching this, like proper football, not like Emery. I'm talking about soccer, real football. Yeah, so you can do hip thrusts. You certainly should be doing hip thrusts. And I'd be suggesting that I'd be wanting you to have done that from really early doors, not necessarily leaving it too late down the line and just starting it after 2 years. But that's why it's really important to have rehab. It's really important to have input post-op so someone can help you with that kind of stuff. How do I know if I have hip impingement? Look, in order to diagnose FAI syndrome, we need more than just clinical tests. We've said that already, but there are a few things that you need. You need clinical tests, you need a painful hip, you need imaging findings, and that's usually X-ray or MRI. So it's a combination of those things that you would need. And sometimes, even at that point, where you might identify FAI syndrome characteristics, where you might find a labral tear, it's still hard to say, like, what's the thing that's causing my pain? Because that labral tear could also be asymptomatic. So at that point, you would look into using maybe things like diagnostic injections to try and figure out if your pain goes after you've had the injection, then it starts to tell you that maybe that's the thing that's driving your symptoms. So there's quite a lot of workup that you need to really confidently diagnose it, but there's loads of things clinically that you might be able to do to pick it up or identify it. But certainly you can't just rely on clinical tests because, like we said already, they are limited. This is really interesting, this one, right? So it says, so number 16, it says, I've got hip dysplasia on both hips. I've got hip dysplasia on both hips. What's the best time for a replacement? Guys, don't disregard the fact that there's a lot of other things that you can do when you have hip dysplasia. It doesn't have to be that you just put up with it, live with it, and wait till things are so bad that you need to have a hip replacement. There are hip preservation procedures that you can have, and there is a lot of physio input that can still be given to try and support the hip, from strength, from function to stability, whatever it might be. So when trying to make the decision about whether someone is suitable to have a hip replacement or not, where I have that kind of input with my patients is this: is it impacting your quality of life? Are you unable to do social things? Are you unable to do activity? Is it impacting your work? Like, is your social life as well governed and decided by the pain that you have? And now those are the kind of discussions that you need to be having. Those are the kind of things that you need to be looking into when trying to identify if someone is suitable and needs a hip replacement or not. So there's quite a big conversation to have there. We can't just say hip dysplasia, wait for a hip replacement. FAI syndrome, wait for a hip displacement. It's a complicated discussion and something that really needs to be considered and balanced out for the context of that individual. What outcomes have I seen? This is question 17 for hip arthroscopies for people who have a pincer. Look, the hip arthroscopy can be an absolutely fantastic surgical procedure, but you need to have the right surgeon doing it. It is a complicated procedure, right? You need the right surgeon doing it, number one, someone who does it a lot, someone who has the skill to do it. You also, after that point, need to optimize recovery afterwards. So you need to make sure that you get your rehab sorted. You need to make sure that you get the right physio input afterwards. But the thing that you have to manage with all of this stuff is you can't do it on your own. You can't just have surgery and then just go off on your own and do your own rehab. Like, you need to get those rehab specialist support. And sometimes that's where people fall short. They don't get the rehab afterwards. They don't get the right level of rehab. And then things flare up. You get a painful hip. And the first thing you think is, I've made the wrong decision. It's not worked. And actually, sometimes a surgical procedure has worked. It's just the physio input hasn't been there. On the other side of things, sometimes the surgical procedure hasn't been great and the physio has. These things need 50-50. They have to work hand in hand. So in order to get those great outcomes, you really need to make sure that you make the right decision with the surgeon and the right decision with the physio afterwards. And those things are absolutely critical to giving you a good outcome. And there is a huge possibility that for many people, you can get a good outcome. Now, there are some factors that mitigate and may be putting people at risk of possibly not doing as well. And that is a lesser healthy hip joint and also psychological risk factors like catastrophization, anxiety, depression, and high levels of stress. All of those factors may well contribute to poorer outcomes. And those are the things that we need to consider. So that brings us on to our last two, because we spoke about point 18. Point number 19. Look, I'm pleased that I'm not talking to myself first and foremost. I'm glad that they released some people watching. This has made me happy. Number 19 is hip bursitis advice. Very, very blank statement question there. Just hip bursitis advice. These are my headline points for this, right? And I've done a video on this on my YouTube channel about hip bursitis. Firstly, it's rarely bursitis, so the focus needs to be on glute tendon rehab. Secondly, if it's focused on glute tendon rehab, and in particular glute med and glute min, where is our focus going to be? Well, it's going to be on progressively loading that tendon. May well start with isometrics, and then it will progress through different positions and angles and ranges. What you don't want to be doing is loads of glute stretches, lots of piriformis stretches. What you don't want to be doing is loads of deep frictions into the greater trochanter, because it's just going to flare it up and it's just going to irritate it. What you also don't want to do is spend tons and tons of time on passive treatment. So it has to be biopsychosocial approach to improve someone functionally, make them a bit more physically robust. Consider the fact that we've got glute tendinopathy that we're trying to progressively load and giving them exercises for that. But cherry on top, don't forget that glutes do not work in isolation. There's more things that work than just the glute. So even if you've got glute tendinopathy, what other muscles can you work with it within your rehab? What other exercises can you prescribe from a rehab perspective that doesn't make it too glute dominant? And equally consider that kind of varied approach from a physio perspective. And also remember that we are treating people that are attached to these hips. It's not just about hip exercises, we are treating people. So it's almost like taking that holistic type approach to manage them as well. But the key things there is really like, don't stress about the bursa, and definitely don't absolutely kill it with stretches, because often that will provoke it. My final question, dun dun dun. I should have made like a really dramatic last question, but I haven't. It's a pretty straightforward one. But last question, nonetheless. Right, question number 20. Are hip precautions post-hip replacement relevant? Short answer, guys. Short answer is no, they're not. But a lot of people still have to do them. A lot of people still get given them. Hip precautions were normally given to prevent dislocation post-hip replacement. They are still given in many areas to prevent dislocation post-hip replacement. But what the evidence tells us now is that they don't mitigate the risk of dislocation, because often the risk is absolutely minimal anyway. There are some heightened levels of risk if you have hip dysplasia and soft tissue abnormalities that might contribute towards that, then yeah, some do it. What evidence there is that it impairs recovery, it feeds into fear avoidant behavior, and it leads into that kinesiophobic type way of being a bit scared to move because of the fact that it is packaged as a mitigating factor for hip dislocations. So if we know that the evidence isn't there, and actually the evidence demonstrates it does slow recovery down, that's why so many surgeons now, and especially where I live, where we've got a centre of excellence, the hip surgeons do not use hip precautions and just say, use common sense. You probably aren't going to want to be doing really deep stretches. You're not going to want to hammer your hip into all these awkward positions. You are going to just want to structure it in a way where your rehab is helping you become a bit more tolerant to these things, and in time you'll confidently be able to do it. However, my biggest bugbear, and to finish on this key point, is that often patients, when they are given hip precautions, sometimes they're not bloody told when to stop, and patients won't know when to stop. Patients are patients. It's not their job to know these things, so they keep doing them for weeks and weeks and months and months. And actually what happens is you've had a hip replacement because your hip has been too stiff and painful, but now your hip is still stiff because you're scared to move it. And that's our job as physios, to kind of support with that. So I did manage to keep it to 30 minutes. I hope you found it useful. It really helps me to understand that these things are useful. So please comment whatever if you have found it useful once I'll load this up. And if it is useful and people have enjoyed it, I will keep doing my Q&A answers like this. Short, sweet, snappy, and you can watch it back. But for those of you who watched, thanks and have a good day.